Chapter 12, Biliary Tract and Upper Gastrointestinal System. Slides 39 through 129 is going to be anatomy review, positioning for these contrast studies. And there's some terminology review as well in there. Be sure that you're going through these and learning or remembering or reviewing, however you want to call it, all these things, because they may show up in your exams. Biliary calculi, or gallstones. Presence of calcifications or gallstones and the biliary ducts. Right upper quadrant pain and tenderness. Stones form in the ducts or the gallbladder. Radiographic appearance is enlargement or narrowing of biliary ducts due to the presence of a stone. Ultrasound or sonogram is done in ERCP or an operative cholangiography. Cholelithiasis. Calcification or stones in the gallbladder. Increased bilirubin, calcium, or cholesterol can be causes. Two stone types, cholesterol and pigment. 75% of these stones are going to be cholesterol. They have radiolucent or radiopaque densities in the region of the gallbladder. On an ultrasound, they look like shadows, or it's called shadowing. Failure to accumulate radionuclide on nuke med scans. Perform a nuke med study or an ultrasound, and if I could say that word, I would tell you that word, but I cannot pronounce that. Milk calcium bile. Emulsion of biliary stones in the gallbladder. Looks like shadowing on an ultrasound. The only thing that you guys can use to image this is going to be an ultrasound. Cholecystitis. Acute or chronic inflammation of the gallbladder, often with cystic duct blockage. Bile restriction causes irritation in the gallbladder, resulting in inflammation. If it's acute, you'll have a thickened wall of the gallbladder with ultrasound, failure to accumulate nuclide, and a nuke med study. If it's chronic, you're going to have calcified plaque or calcification in the gallbladder wall. Again, ultrasound or nuke med study are going to be your modalities of choice for an acute, only an ultrasound for chronic. Neoplasms, new growths, malignant or benign. Malignant growths in the gallbladder can spread quickly to the liver, pancreas, or the GI tract. As seen as a mass with gallbladder, liver, or biliary ducts. Extensive calcification of gallbladder wall, seen on ultrasound or CT. Biliary stenosis, narrowing of the biliary duct. It looks like elongation, tapering, or narrowing of the common bile duct. An operative cholangiogram or an ERCP is how this is going to be viewed. Echolalia, cardiospasm, motor disorder of the esophagus. A reduced peristalsis in the distal 2/3 of the esophagus. Thoracic esophagus may lose peristalsis and become dilated. Megaesophagus is what this will look like. Stricture or narrowing in the esophagus, which makes zero sense when it just said it may become dilated, but apparently that's what it looks like. Radiographic exam is going to be an esophagram with fluoroscopy. Anatomic anomalies. They're congenital or caused by disease. impaired swallowing mechanisms, maybe due to stroke or foreign body. They look like abnormal peristaltic patterns, various radiopaque and radiolecent foreign bodies. You'll perform an esophagram with fluoroscopy, a functional study, endoscopy for foreign bodies. Barrett esophagus. Barrett syndrome, replacement of normal squamous epithelium with columnar-lined epithelium ulcer tissue in the mid to lower esophagus, may cause stricture in distal esophagus, may cause peptic ulcer. Radiographic appearance is a stricture or a streaked appearance of distal esophagus. Radiographic exams include an esophagram and a nuclear medicine scan. Carcinoma of the esophagus. Adenocarcinoma may have dysphagia or difficulty swallowing, bleeding, pain during meals. Other tumors like carcinosarcoma, which produces a large irregular polyp, and pseudocarcinoma. These look like a point of a stricture, narrowing, or atrophic changes in mucosa. You'll perform an esophagram or a CT scan to visualize these. Dysphagia, or difficulty swallowing, caused by congenital or acquired condition, trapped food, paralysis of the pharyngeal or esophageal muscles, or inflammation. It looks like narrowing or enlargement of the esophagus, depending on cause. Use a esophagram with fluoroscopy for a functional study. Esophageal varices, dilation of the veins in the wall of the distal esophagus, often seen with acute liver disease. Looks like narrowing or worm-like appearance of the esophagus. We'll do an esophagram or endoscopy. Zinker diverticulum, large outpouching in the esophagus just above the upper esophageal sphincter, caused by weakened muscle walls. Enlarged recess or cavity in the proximal esophagus is what this will look like. You use an esophagram or endoscopy to view these. Basor, mass of undigested material that becomes trapped in the stomach, usually made up of hair, some vegetable fibers, or wood products. Trichobasor is ingested hair, which looks really disgusting. Phytobasor is ingested vegetable fiber and seeds, which doesn't look any better. The appearance radiographically is filled defect or an ill-defined mass within the stomach. You're going to use an upper GI or endoscopy to evaluate these. I did include some images of these things in the next few slides. I hope they don't gross you out, but it is what it is. Diverticula in the stomach or the small intestine. Outpouching of a portion of the mucosal wall. 70 to 90% are in the posterior aspect of the fundus. Complications could be perforation and inflammation. Appearance is outpouching of the mucosal wall. You want to do a double contrast upper GI. Gastric carcinoma, 70% of all stomach neoplasms, with 90% of them being adenocarcinomas. Radiographic appearance is going to be irregular filling defect within the stomach. Double contrast upper GI will be performed to evaluate this. Gastritis, inflammation of the lining or mucosa of the stomach. Acute gastritis is severe symptoms and discomfort. Chronic gastritis is intermittent condition brought on by changes in diet, stress, etc. It's going to look like the absence of rugae, thin plastic wall, speckled appearance of mucosa with acute cases. You use a double contrast upper GI with this. Hiatal hernia. Portion of the stomach herniates through the diaphragmatic opening, common in 50% of the population over 50 years old. A sliding hiatal hernia is weakening in a small muscle, esophageal sphincter, between the terminal esophagus and the diaphragm. Looks like gastric bubble or a protruding aspect of the stomach above the diaphragm or Schatzki ring. Radiographic exams are going to be a single or a double contrast upper GI. Hypertrophic pyloric stenosis, otherwise known as HPS, common gastric obstruction in infants. Hypertrophy of the antral muscle of the orifice or at the orifice of the pylorus causes projectile vomiting, or otherwise known as emesis, after feeding, pain, distension of the abdomen. Radiographic appearance, distension of the stomach owing to obstruction of pylorus. Upper GI or an ultrasound will be performed. Ulcers, erosion of the stomach or duodenal mucosa can lead to perforation if not treated. A duodenal ulcer is a peptic ulcer in the duodenum. A peptic ulcer is ulceration of the mucosa membrane of the esophagus, stomach, or duodenum caused by acid gastric juice. The appearance is a punctate collection of barium and a halo sign. You'll use a double contrast upper GI to perform and evaluate this pathology. Emesis, vomiting, common with some GI conditions. Hematoemesis is vomiting of blood. I'm sure I said that wrong, and you guys can laugh if you'd like.